The title of the thing is Research in Boarding, so I just want to say that the research in boarding is very much like the research on dying. In 2015, the CDC reported that people died in the United States. They are currently evaluating the 2017 data to see if the same thing happened. And boarding, if you look at the literature over the last 20 years, it's the same thing that gets repeated again and again. But we are going to do some real-time research here. I'm an old emergency physician. I used to do things very differently than I do now, but fortunately I'm in an academic setting, so I learn new techniques to keep up and do what I need to do. I do want to make a point as there's so much of a philosophy in emergency medicine is get them in and out as fast as we can. And I do want to say that at some point we need to start to put our foot on the brake because we're seeing increasingly complex patients. They need to get to the right place in the hospital because the hospitals are all siloed now. So putting the patient in the wrong place can be very dangerous for them. We're expanding another number of services like critical care. It's starting in a few places, but it's rapidly spreading. Observation. You're supposed to get a patient in and out in 2 hours, except for these that you keep for 18 hours. So I think one of the biggest fundamental changes is the change in scope of what we do, and the change in that scope means that we really have to slow down. I'm not going to talk at all about how well you run your emergency department, but there's a lot of pressure on you to run it well. That's why everyone is here. And in terms of crowding and why people wait to be seen, the research on this has been pretty clear up to date, and this is a summary slide of it. It's somebody else's fault. We complain about boarding, and everybody else looks at us and say, look, it's because you have too much business, that's your problem. And when somebody walks in a busy emergency department, they can't figure out whether it's because you're busy or because you're boarding patients or whatever else. So here's our first little research tidbit. We took a look at an emergency department that sees 100,000 visits a year, and I'm going to just round these numbers off. There's about 9,000 hours in a year. We looked at each hour, and we asked the following question. Are there patients waiting more than an hour to get in the room? Number two, are there boarders in the emergency department? And we did the following calculation. If there were 10 boarders and 5 people waiting to get in the room more than an hour, we blamed it on boarding. If there were 10 patients waiting to get in the room and there's only 5 boarders, we blamed it on the ED being too busy. So to what extent in our environment with boarding do we blame it on boarding instead of we're too busy? Because you can't tell just by looking. So these were our results. Out of 9,000 hours, close to 4,000, somebody had to wait more than an hour. 41% of our patients had to wait, 17,000% of our patients had to wait more than an hour to get in the room. How often was it because of boarding? How often was it because the ED was too busy? 17 out of the 3,649 hours, it was because the ED was too busy. The rest of the time, if the boarders had not been there, mathematically, there would have been a space for them to be seen. So overall, of all the people who waited more than an hour to be seen, 1 of 6 we could attribute to boarding, and 1 of 400 we could attribute to we're just too damn busy to see you. This is not to say if you eliminate boarding, you now have a perfect emergency department. Now you have, as Kurt talked about, the theory of constraints. Once you remove that constraint, you discover other things. So if we think about this, if we take this data and we try to figure out what's my problem in my emergency department, it's exit block. We can't get people out. There are other questions that I'm going to pose that really I think we need much more research on this. Our whole mission has been to get them in and get them out as fast as possible. For admissions, we complain constantly. They want us to do extensive workups in the emergency department and whatever. And the question is, for our length of stay, that's bad. But for the overall length of stay for the patient, is that good or bad? We don't know. I will tell you one study we did at my place. One of our residents did this study. What happens if, when you're admitting somebody to the hospitalist service, they request that you get a neuro consult in the emergency department before admission? So we found that most of those led to, surprise, surprise, an MRI. So you got the neuroconsult, the MRI, and then the neuroconsult finished, and then you admitted patient. It added 12 hours to the ED stay. That sucks. What happened on the inpatient service? This was the most amazing thing I ever saw. Day 1, the hospitalist calls for the consult. Day 2, the consult comes and asks for an MRI. Day 3, the MRI is ordered. Day 4, the MRI is resulted. And day 5, the neuroconsult is completed. That was the average result. The other thing we don't look at is what's the downstream impact of what we do. Oh, I have to stay in the box. I'm trying to, can I think outside the box? Okay, I'm going to stay in the box here, folks. I'm sorry. So what's the downstream impact of what we do? I'll give you an example of our results, which I think are in contrast to what some other people may have found. We do a lot of CT coronaries in our place for people that come in with chest pain. Now there's this heart score that you can use and you can do it. It's much quicker than the workup we do. It means you can kick the patient out of your ED and it's safe to do so, but you're also kicking the can down the road to someone else, to the cardiologist. So this is what we found in the group that because we had it available half the time. So we compared those two groups, the groups that got it and the groups that didn't. 80% admission rate versus a 10% admission rate. A 5-fold decrease in ED visits over the next year. 10-fold decreased radiation exposure over the next 2 years. Only 1/3 were actually ended up being referred to a cardiologist. So if you add those things up, these are sort of the downstream things we need to think about. Everybody knows the emergency department's a more expensive place to see a painful arc syndrome, a painful shoulder. When I see you, I diagnose you, I treat you, and it's a greater charge than when you go to see a GP. But when you go to see the GP, do you get the same care, or do they do a thing called, let me refer you to an orthopedist? And is referring you to an orthopedist cheaper than being seen in the emergency department, along with the MRI, the injection of the shoulder, et cetera, and so forth. So our value, we are sort of ED-centric on looking at what happens today, but I think a lot of research needs to be done on what happens downstream. Now, here are some things that are peculiar, that I puzzle on, and I would ask anybody to consider doing this research. Here's question number 1. Why does everyone who comes in need a bed when they're available? But once the beds are filled, everybody can be vertical? That's one question I have. We went through an era where we boarded and nobody really gave a damn. Finally, people gave a damn, and now we have huddles, emails, and alerts. Before that, we would get beds at 6 o'clock in the evening. Then we had huddles, emails, and alerts, and we would get beds around 6 in the evening. So we increased the number of huddles, emails, and alerts, and we're getting beds around 6 in the evening. How many people have had the same experience? So one question I have is, how do we stop stuff that's not effective because someone reported at a CQI conference that it was effective, therefore we're all obliged to do it? Here's my question to cardiology. Why don't you see your patients in a hallway? Why don't you have a cardiologist at triage? And why don't you complain about all the unnecessary visits you have and all the unnecessary testing that you do? Because we certainly do those things, but it doesn't seem to be happening elsewhere. So let me talk very briefly about the consequences of boarding, because I know all of you are familiar with this, but it's needed to set the table for what you can do. Increasing walkouts is harmful to the patient, and it's harmful to the bottom line of your institution. If you board patients in the emergency department, study after study after study after study has shown that it increases your length of stay for about a day. And there are reasons why that happens that I'll get to downstream here. But this is what you're doing when you're boarding and when you're having walkouts, is you're tossing money down the toilet. Obviously, we all know, familiar with the stresses on the staff and the increased medical error, and I don't want to belabor that. Physicians and nurses are both harmed. There's a 5-fold malpractice difference in patients whose care is delayed as opposed to patients whose care is initiated within the first 30 minutes of arrival. The pain to our nursing staff, when you can sit in a meeting and talk about it, but when you're working in an emergency department and you see a nurse that's overwhelmed, that goes in to get a medicine for a patient, and in the Pyxis room, which is glass enclosed, she goes in, she closes the door, she's taking out medicines, and she just bursts into tears. Just cries like a baby. And for about 60 seconds, and then stops, clears, collects, and then goes out and does their job. It's really, it's an amazing, a horrible thing to see. There has been an arc of literature over the last 15 years that concludes the same thing over and over and over and over, that this is lethal. Drew Richardson was one of the first people to really do a great job on this, and also Peter Sprivelis, I'm not sure how to pronounce his name, Sprivelis, or but if you follow the arc of this research over time, it's the same conclusion over and over. We actually looked at our boarders as to how long they boarded, and if you boarded more than 24 hours, your mortality rate tripled compared to if it was less than 2 hours. So boarding is a lethal weapon. How do you fire this lethal weapon? Do nothing about it. That's very simple. It's a lethal weapon. That's all you have to do in order to fire it. This is some research that personal research that I have done. Sherry mentioned that I went to MIT and I minored in mathematics, so I've done some mathematics on how long a week is. Now, in 1960, in a hospital, a week was 5 days long. 95% of your admissions were elective. The length of stay was 10 or 11 days. It made sense to have your hospital run 9 to 5 Monday through Friday and have a skeleton crew on evenings, nights, and weekends. Life has changed. This should be, say, 2018, typo, sorry. Depending on where you work, 50 to 80% of your admissions are unscheduled. They come through the emergency department. It's 7 days a week. It's evenings, it's nights. And we still run our hospital so it's 9 to 5 Monday through Friday. Monday through Friday does not represent 5/7 of the week. Monday through Friday weekdays represents, and this is where my math comes in, 24% of the week. So 75% of the week we are running at half-mast. And the consequences of that are clear from the literature. I love the debates on this, like in the British Medical Journal. Well, is it just a statistical anomaly that we're killing more people on weekends, or are we actually killing more people on weekends? You can ask yourself from firsthand experience, how many people from firsthand experience are certain that they have had patients that died on weekends because of delays in care, et cetera, and so forth? Raise your hand. So probably only 50 people raise their hand. What a disappointment. So this, again, is a lethal weapon that all you have to do to fire the weapon is just continue doing what we're doing. You can build a bigger ED. This has been studied. This has been researched. If I'm boarding 10 patients, so you're going to give me 10 more beds, I'm going to end up boarding 20 patients. As my surgical colleagues would say, the cure for constipation is not to add more colon. You can add beds on the inpatient side, but that's very expensive. In New York, it's about $1 million to add a bed. It's about $600,000 to staff it. In California, this is $1.5 million and about $1 million. So you can solve it this way, and that's a nice way to solve it because we have so much money floating around, right? Money's no concern to anyone here in the room. The other thing we do is we meet. We meet and we meet. We have a memo about the meeting, a luncheon about the memo, and a memo about the luncheon. And finally, people get exhausted about meeting, so they stop meeting. But once you stop meeting, then everybody thinks the problem's gone away. So then now we have to do lean processes. And we do a lot of lean processes in our emergency department. Let me give you 2 examples. Our door-to-doctor time is 20 minutes, and our order of a CAT scan to actually finally having it read is 4 hours. Which things should we focus on? The door-to-doctor time. And when you do, it went from 20 minutes to 15 minutes, you're a big winner. Oh, let's celebrate. Hurrah, hurrah. But what we don't do is we don't stand back and ask, if I work on this project and I really work on it hard and I'm wildly successful, is the day going to be any different for the patient? And I don't think moving from 20 minutes to 15 minutes really is going to make that much of a difference. Moving from 4 hours to an hour might make a big difference on the CAT scans. But when you go to quality conferences, how many presentations do you hear on, we tried this and it didn't work? Those guys aren't invited to speak. At least what I've come to see the CQI process at our place as very similar to my son's soccer team. It didn't matter that they didn't win a single game. They all got trophies anyway. And and we're in the business of giving out trophies. There's hospital awards, there's department awards, there's all sorts of awards that we get. So you have to ask, are these changes real, or is it just putting lipstick on a pig? Throwing squirrels at a big problem is not gonna make it. So if we're going to deal with boarding, the question is, in order to improve that exit block, they've got to go somewhere. They have to have somewhere to go. So is there a way in your overwhelmed system you can increase capacity? And for those times that you fail, what's your plan for failure? So, what I'm going to talk about is, I want to frame. For instance, ACEP has this manual on good ideas for what to do in your emergency department. I think there's 27 of them in there. 24 of them will not help you with boarding. They just won't. They'll help you with your internal mechanics in the ED, but they will not help you with boarded patients. So it's important to understand that if you want to fix this, you got to pick the right intervention, but you also have to have a sufficient degree of that implementation, and I'll show you some examples of success and failure. The other thing that I find very dangerous in our system is once you decide, okay, we're going to do this, we're going to implement this, we're going to pick this intervention, you get a group together and they start working on it, and that's considered the success. The result you want is replaced with the process. Anybody work in a place where you hear, we're working on it? When you're working on it, it means you hadn't fixed it yet. And although, yes, you have to go through the process is not itself the result. So, and for all the stuff I'm going to talk about, you need real leadership. And the reason you need real leadership is that there's an authority gradient here. How many people work in a place where beds for, you know you're going to have 50 admissions today. How many places set aside 50 beds for you? Anybody? How many places set aside beds for the elective admissions? You're looking at an authority gradient. If you have to petition services to admit patients. When they do admit them, they push back on you and say, well, you got to get this, this, and this before I'll admit them. These are called authority gradients. In order to override that, you either have to have a sudden, you need to spray everybody with oxytocin so there's goodwill and trust, or you have to have leadership that says, this is what we're going to do. So I'm going to tell you the home runs of how to improve capacity, but there's an amazing story that goes along with this. These are improvements that do not cost anything. They do not cost more staff. They do not cost more money. In fact, it ends up being tremendously rewarding financially to the hospital. So the first part of this is that the weak matters. Boston Medical Center, they were a big damn mess. So they hired two consultants, a guy named Eugene Litvak and Don Berwick, to come in and fix their emergency department. It was on fire. It was diversion a third of the time. They had crowding and boarding. They came there. They discovered some remarkable things. In this highly chaotic emergency department, somehow they had about the same number of admissions every day. What they also discovered is that the hospital was like Groundhog Day. It was a sudden new discovery every day. Really? We're getting admissions from the emergency department? Go figure. Wow. But they also looked at the elective admissions and they found, the elective admissions we can control, but they're completely uncontrolled. Is that they just come in whenever the person that's going to do the job wants to do it. And what they found is that the electives and the EDs were competing for the same resources, for the same ICU beds and whatever else. So they went about doing surgical elective smoothing. And what that meant was that you had a steady flow through the ORs, you had a steady flow every day to the ICUs. Now, the surgeons didn't like this, but this was the result for the surgeons before and after. 771 elective patients were delayed or canceled before implementation. This slide is wrong. That number should be 6 elective patients were delayed or canceled after implementation. They went to Cincinnati Children's, they were a tertiary care facility that could not take transfers because they were overwhelmed. They were having crowding in their emergency department. They were going to build a $100 million 100-bed tower, and while they were in the middle of architectural drawings, somebody came in and they did surgical smoothing. The end result was that they canceled the building. They actually built this was 10 or 15 years ago. They actually built it last year. It represented and again, I don't know if this money is important to your institution, but they've had a $130 million swing. They were able to increase their volume without adding ORs, and they ended boarding simply by doing smoothing. So let's look at the day itself and what you can do within the day, which is the discharge time. NYU, so there's some studies on this that show early discharge time is important. NYU took this on for the following reason. They found that if admissions made it to the floor after noon, that their length of stay was increased by 0.6 days. And we found in the ED, if they don't make it up till the evening, their length of stay is increased by a day. Why is that? They're not getting, the antibiotics they're getting is the same and this, that, and the other, but they're not getting care management, they're not getting PT, they're not getting the consults until the next, a lot of stuff gets pushed off into the next day, and that adds to your length of stay. So they implemented, they were at about 5% discharges before noon. They are now at 42% discharges at noon. How did they do that? Is that their leadership said, you're going to do it. This is our target. Our target is 30%, and once they got going, they got it up to 40%. So that was, I won't show you our data because it's too embarrassing, but we didn't do it that way. We did it through a group collaborative. We've had no change whatsoever in the last 7 years. The weekend, by the way, NYU dropped their O to E by 0.8 days. I am told that if you decrease the length of stay at our institution by a quarter of a day, it's worth about $35 million. Again, at some point, I think that's real money. Montefiore was very much like us, 100,000 patient visits, an average of about 30 boarders a day. Oh, it's horrible, it's horrible, it's horrible. They're losing business, they're having walkouts and such and so forth. So the COO there took it upon himself, this wild notion that I'm going to get patients out on weekends. I'm going to increase weekend discharges because there's about a half the rate of discharges on weekends as weekdays. The end results of this, which was successful, but it required him coming in every weekend, bringing his managers with him in to make sure that PT and echo and all this sort of stuff happened on weekend. By increasing their discharges, these are the end results. No boarding. In fact, they closed a 30-bed unit because they didn't need it, and it was only a $70 million swing. So maybe that's just chump change and not something that you're interested in. So you, in all of these examples, you improved capacity and you made a ton of money doing it. And you made life easier for everybody. So if I ask at my place, do we have a problem? We have 600 beds, we're boarding 30 patients. We at the time of this data, we were about half and half. 50% were coming from the ED and 50% elsewhere. The blue you can see is relatively smooth. That's the ED volume. And then the red is the elective volume. This is the surgical non-ED admissions. That does not look like a 5-day-a-week to me. That looks like a decrescendo week. But this is schedulable. You have control over this. At the beginning of the week, you're overwhelmed. The ORs are running until 10 or 11 o'clock at night. The PACU's fill because they can't get patients in the ICU. And then Thursday and Friday, it's group hug day. So you have overtime, you have wasted time. Now, they claimed that they sort of worked on this and they smoothed it out. So this is data that I picked out from about 4 or 5 months ago. And this is the curve of the blue represents the elective admissions. Now, I want to show you what do you think that red line is? Boarding hours in the ED. Do you notice any sort of relationship between these two curves? So this is our discharges. The big discharge day is Friday. The Saturday and Sunday are really low. So at our institution, if you're discharged on a Saturday or Sunday, your average length of stay was about 4 days. If you're discharged on a Monday, it was 6.66 days. If you look at the New York Sparks data, it's about 4 days versus 7.7 days. That's the impact of a weekend, but it's also the opportunity of a weekend. But if we smooth, so what we looked at, asked the question, if we smoothed over 5 days, in terms of admissions and discharge, how many beds would we need at our institution and not have boarding? And if we actually were a 7-day-a-week hospital where Sunday was just like a Wednesday, this is what it would look like. So we're at 600 beds now, and we're boarding all the time. If we smooth across 5 days a week, we could close a 30-bed unit, and we wouldn't have boarding. And if we were actually a 7-day-a-week hospital, we could close 100 beds and be able to deal with the volume we have. So the way you fix your lack of capacity is to use it in a sensible way. But no matter what you do, if you run your place as smart as you can, you're still going to be very close to, you got to run close to the margin. And if you run close to the margin, you are occasionally going to run over that. And so you're going to be over capacity no matter what you do. So the option number, so you know that you're going to fail. So option one is just to stick your head in the sand and just ignore it, or you can do little projects that help. But there's a solution there. Again, because I went to MIT, I did some architectural studies of our institution. And we put patients in rooms and hallways and whatever else. And I found out in architectural drawings that other places in the institution have hallways too. So I said, well, why don't we use them? Now, if you ask a lay group, what's the best strategy? You got 10 units and you got 20 patients that you have to distribute across those 10 units. What lay person would say, put all 20 on one unit? It's insane. But because that's the way it's been, we can osmose, okay, that's the way it's going to be. So we came up with this radical notion that, you know what, we can, at least for half these patients, the lower acuity patients, we can distribute them to other places. We happen to use hallways. You could use Solaria or whatever else. But it was, this is not to help the ED, really. It's to help the patient. Where does the patient get the most nursing care? Where do they get the quiet? Where can they sleep? Do they get to have warm food, or do they have to be a damn hunter-gatherer in order to eat? So things, choices like this, and if you believe in patient safety, you have to ask, am I safer here once I've been stabilized and everything, or am I better in this setting? Now, what's wrong with this picture is there's actually supposed to be a curtain around them. They have a call bell. We have wireless tele, all this sort of stuff. And you have to decide what bathroom they're going to use. It may be a staff bathroom. It may be shared with somebody else. And that was an initial objection. And I said, well, from the patient's point of view, they're sharing a bathroom with one person instead of 70 people. I think they would think that's a big improvement. So what we're saying is in a place that is burdened with, in our place it's 50 to 40 boarders, we're asking you that has a 30-bed unit to make it 31 or 32. And during the years we've done this, it has never been a workload issue for the nursing staff on the inpatient units. It's just not been. There are many variations on this. We have recently had to shift to 3 per unit and had to open up some other alternative areas to put patients there because our capacity has really gone crazy. The option that we've explored now, which I think is a much better play, is to identify the patients you're going to discharge and move them out rather than putting the fresh patient in the hallway. Put the patient that's ready to go home in the hallway. You have problems with early discharge? That's a real good way to fix it. Because once you put that patient ready to go home in the hallway, they'll want to go home. Now, if you ask people why people don't, ask the docs why the patients don't leave early, it's because they say, well, they don't want to leave until 5. Their families don't want to pick them up till 5. All of you that work in an emergency department, if you see somebody at 10 o'clock in the morning, you're finished with them at 11, do they say, you know what, I'm going to wait till 5? No, they leave. They figure out how to leave. And it's the same population upstairs. Now, we showed that this was a safe thing to do. It actually cut the length of stay by about a day. In terms of patient satisfaction, we actually asked patients who were in our hallway, who were also in the hallway upstairs, which place did you prefer? Based on, and we asked all sorts of subcategories about nursing, safety, environmental stuff, and overwhelming 87% wanted to be upstairs. I think 13% smoked, and they wanted to be near an exit door. But and other studies have, when they use it in the way it's to be used. Grant Ennis did a great job. He did the whole province of Alberta, and they showed overall in the province a decreased length of stay of a day by implementing it. LA County implemented it, and this is the NEDOC score, red versus black, and it dropped to almost nothing. Although they never actually put somebody in the hallway. What they did was that they just found hidden beds upstairs and fixed that problem. So the bottom line is, when you want to attack boarding, you can't do the little tiny stuff. Although once you fix it, that little tiny bird can become a big bird, and now you have to address that issue as well. So it's a safer thing to do for the patient. It improves your capacity. It's easier for the doctor, it's easier for the nurse, and it's better for the patient, and the hospital makes a lot of money. So that's a formula for success, but in order to have that success, you need leadership, but again, because the leadership is necessary to realign the authority gradients so that this can happen. So smooth across the week, across the day and tackle the weekend, have a full capacity protocol, and you'll make a lot more money without killing so many damn people. Remember, you got to pick the right intervention, but it's got to be sufficient in degree for it to work. Going from 5% leaving before noon to 7% leaving before noon deserves a prize, deserves a luncheon, but it doesn't fix your problem. And don't confuse process and results. It's hard work, but the way I think of this is if this is where you are now, you've got to take your institution through some pain. But once that plane lands, you're in the Fiji Islands, and you're happy that you did what you did.